Welcome to the latest edition of Venus Edge 3T, and the T that we're talking about today is technology. So we're going to have a series of little webinar events where we're going to talk about different thrombectomy devices, and this is being led today by Dr. Bill Marston, who's going to do Q&A, and we're honored to have as a presenter Dr. Patrick Muck from Cincinnati, Ohio, who's going to share with us a case of intelligent aspiration with the Penumbra device. So without further ado, I will hand it over to Dr. Muck.
Kathy and Bill, thanks so much. It's a pleasure to join you, and thanks so much to the Venus Edge. We will get right to it. This is Bill. Bill's a 73-year-old gentleman who's a Kentucky goat farmer who I was asked to see 23 days after his hip surgery when he had an orthopedic injury resulting in his hip fracture. He went on to have it repaired. He couldn't participate in his physical therapy. I was asked to see him for his left lower extremity edema. Of course, the duplex confirmed a large iliofemoral DVT. Like so many other groups across the country and world, we strive for single session therapy and embrace the new technologies. For Bill, we brought him, put him prone, went a popliteal approach, put a 12 French sheath in, crossed the iliofemoral thrombus with a hydrophilic catheter and wire, placed a exchange out for an Amplatz. We then employed the intelligent aspiration. Takes about 45 to 60 minutes, little to zero TPA, IVUS, FDA stent, etc. So for those of you who are not familiar with this is what it looks like from Penumbra. What it is intermittent aspiration. It's like putting an iPad on top of your engine over here. And during aspiration, it intermittently turns off and on through these dual pressure sensors and this microprocessor. When it's low pressure, it assumes that it's in liquid blood and the valve is closed. When the pressure is high, it assumes it's in the non-circulating or the thrombus, and the valve is intermittently opened up to allow aspiration. You couple that with the latest stainless steel hypo tube. It's a multi-pitch laser design with a very maximized sweep, and it's a 12 French system with a 0.131 inner lumen. You couple the two of these, and this allows for effective single session thrombectomy. Here you can see the work of our orthopedic surgeon. Here we're into the IVC, confirming there's no long tail extending up into the inferior vena cava. On your left, you can see we're working the catheter from the common iliac all the way down. A common question is, are we worried about losing wire? And as you can see here, I'm never worried about losing wire in the femoral or really in arterial system. Here's the separator. Here we are. This image shows you how pushable, torqueable, and trackable it is. And bear with me just here for just about 15, 20 seconds.
So I was going to click the little clicking is open vessel. You have patent flow coming back into the tubing. There you go. There you go. Right there.
And you could hear it went from clicking, meaning open vessel, to non-clicking, meaning it's engaged in the thrombus, and you just let the catheter do its thing. Here's what it looks like on the back table. It allows the circulating blood to be left behind, and the non-circulating blood, the thrombus, to be effectively removed. Here you can also see how pushable and torqueable it is. So it really allows for a wall-to-wall, effective, complete thrombectomy. And a common question is, will it remove chronic thrombus? And here you can see some of the chronic material that's removed as well. When you're done, you go on, do your IVUS, identify the iliocaval confluence, and went ahead and placed a effective Venovo stent for Bill once we identified his underlying IVUS lesion that led to it. Here you can see before and after. To the left, there's really no lumen, which led that, coupled with his general anesthesia, his lack of calf muscle pump, etc. Here it is, that led to his iliofemoral thrombus. And here you can see a nice concentric lumen with good aspect ratio and an excellent result for Bill. So when you're done on the left, this is what it looks like, wall-to-wall effective thrombectomy. And here it looks like before we went on to place our Venovo stent. And here's what it looks like on the back table. This is all what we were able to easily extract. And again, it only took about 60 minutes. Here, we actually brought him in. He was already on Eliquis. Oftentimes I use Lovenox. Being that he was already on his Eliquis, I didn't stop it. So this was percutaneous complete thrombectomy, and he was outpatient with minimal blood loss. Oftentimes I get asked about closure. We typically just use a purse string, wad up a bunch of 4x4s and wrap it with an ace wrap. I have used the Vascade from Cardiva before. It's 12 French called the MPV, but I think most of the time all you need is the closure technique I mentioned. At the end of the day, here's all your DVT tools. 12 French sheath, whether it be a Gore dry seal or a cook sheath, Cat 12 Lightning. I'll use a separator almost every time to help clean out the lumen. Ivis, Fenovo, Abre, Zilvervina, the stent, wall stent, your stent of choice. And I'm happy to say that we submitted our early results. What eventually this is going to be called, as I'll show you here in a second, is computer-aided mechanical aspiration thrombectomy. So we took our first 16 patients over the last 6 months, or excuse me, 12 months. As you can see here, some of the follow-up was out to 6 months. And I'll show you the results here. We've submitted it to the JVSVL. We've already gone through 1 round of revisions. I'm due to submit the rest of them by October 16th. The bottom line is the baseline characteristics are pretty much what you would see, but the highlights are right here. We looked at thrombus removal. We were able to remove greater than 70% of the thrombus in the iliofemoral segment in all 16 patients. When you broke it down, 15 of the 16 were able to be treated in a single session. 1, we ran a short burst of lytics. And as you can see here, this is where the Lightning technology really shines with a blood loss of only 160 cc's. So I think in conclusion, these newer VT devices are here. Single session DVT therapy is here. Bloodless thrombectomy is here. And thank you so much for your time. I appreciate your attention and certainly the invite.
Thanks, Patrick. That really was a great summary of the Lightning technology. And I had a couple questions. One is really a technical one, having done some cases with the Lightning device. You know, you've got the time frame when it's clicking, so you know it's doing its turning on and off thing to minimize your blood loss, which really is pretty effective in my experience. And it's important because with the 12 French, you'd suck a lot of blood out in a hurry if you didn't have it. But then once it stops, it takes a little experience to understand, is it really working on clot or is it just getting stopped up, and how to use that separator. So could you focus a little bit more on your technique to really maximize the clot removal using the separator and keeping the thing from getting clogged up? Because it's kind of a pain if you had to take it out and flush it and then reinsert it.
Yeah, so you're right on the money with that, Bill. And so what we do is when we employ put device inside the body, we turn it on as we're going peripheral to central, and obviously all the way up into the IVC. What you'll hear is, as you mentioned, when the clicking stops, you got to give it about a minute to 90 seconds. What I then do is if the yellow light's flashing, that indicates either the lumen of the device is clogged, for which I'll continue with the separator. I'll go up to a segment that I've already treated or up to the IVC, and sometimes get into that area that it's low pressure again. That'll allow it to aspirate out. If, however, it goes longer than a minute and a half or 2 minutes, you're right, you got to bring it out of the body. You got to flush the catheter. You got to disconnect the tubing, flush the tubing. Don't forget to flush the TUI Borst as well. And I would say on average, that's actually one thing perhaps we ought to look at in the future. I would say it's somewhere between 3 to 5 times you take it in and out of the body. So, and all in all, though, it's, again, the time is only 45 to 60 minutes.
Yeah. And so along those lines, is there a certain time frame or duration of the clot that you would start to say, well, maybe it's not the best device after a couple of weeks or whatever? Do you have a certain time frame of clot age?
We arbitrarily, in our mind, when we hear, symptom duration, obviously not diagnosis based on duplex, but when did your symptoms start? When we get up to 14 days, then that's when we start to think, maybe we ought to run a short burst of lytics for 6 to 8 hours, 2 milligrams an hour for 6 hours, start it in the morning, bring them back at 2:30 or 3, and then run the Lightning 12 for, several runs for up to an hour. All those patients, as you'll see, hopefully in a publication, were all less than 2 weeks in duration.
And are there any complications or side effects that we should, be careful about with the device?
No, it's pretty soft and atraumatic. The separator is very robust, but the tip of it is also very atraumatic and malleable. So I've not seen any perforations. I'm certain that there has to be, being honest, there has to be some subclinical PEs that we've caused, but I've certainly never done it, nor any of my partners. And we thought, this patient just had shortness of breath, tachycardia, et cetera. There has to be some small subclinical ones, but certainly nothing major. And that's why I highlighted with that one shot. You always want to get up into the IVC, as we all know, make certain there's not a big tail extending all the way up to the renals or something like that. If that were the case, I'd be a little more cautious, run some lytics with or without a retrievable filter, that's dealer's choice.
Kathy, I'm sure you've got questions too.
Yeah, I have one main question, not so much specifically about this device, but thrombectomy in general. So there had been an evolution of thinking from just anticoagulation alone to catheter-directed thrombolysis. Then we had the ATTRACT trial that gave some people some pause about the risk-benefit ratio, particularly in patients over 65, like this gentleman, where you might say the risk isn't worth it for the potential benefit. So how do devices like mechanical thrombectomy devices change the game, change the picture of who we should be treating since the ATTRACT trial?
Yeah, at the expense of sounding cavalier, at the end of the day, it's just a 12 French large IV, to be honest with you. Now, with that, obviously, there can be access site issues and whatnot. I think that the goalposts have just dramatically changed. No longer do I feel kind of idiotic going up to a patient in year PGY 30, whatever I am anymore, I don't know, and saying, hey, I want to make your leg swelling better, but oh, by the way, you might have a stroke. I always felt like I sounded so uneducated despite being in school till I was 32. So I think these new technologies, they have moved the goalposts. No longer are we worried about, hey, I might cause a stroke in running lytics. It's now simply, we're going to go up and aspirate this out. Worst case scenario, we don't have a good result. You can still, as you can see, the one patient, as well as some others with IVC filters, we left lytic catheters through the 12 French. It was mainly the IVC occluded filters, but that's the worst case scenario. But I think at the end of the day, the game has just totally changed with this new technology that allows for a very effective wall-to-wall thrombectomy. And then the other thing that's in our secondary endpoints is there's really no AKI. We're not, causing hemolysis and worrying about, AKI as we've seen in other technologies.
Well, I think it's great that you're developing data, and hopefully these series like yours will get larger, because that's really what we need to see what the longer term outcomes are with these compared to other lytic strategies. And one final question from me. We know, Pat, you're a real expert in mechanical thrombectomy. There are a whole bunch of different devices out there, and I know you've used a lot of them. Where do you see this device compared to others? Where is it the best one? And are there other situations where you use other devices?
Yeah, so I think your question previously kind of dovetails into that. I think that this device, what I see is that it's going to shine in 2 to 3 weeks out in duration, as you saw with our patient Bill. I personally think in the future, we're going to be treating patients further than 2 to 3 weeks out, as we know with C-track coming and whatnot. I think perhaps some other technologies may be a little bit better in those situations, but it remains to be seen. And the one thing I like about it is it's very atraumatic. I don't feel like we're injuring the wall. I don't feel like we're damaging valves with this device. But I think, admittedly, I think that it's going to play a role, but several devices are going to play a role depending on how far out the treatment paradigm goes with the symptom duration. I think personally, we're going to be treating out to 30 days in the future. And I think that's where perhaps other devices thus far may work a little bit better, but I think this one shines early in the first couple of weeks.
Excellent.
Thank you very much for presenting this case. It was very fun talking with you.
Hey, I appreciate
Pat.
the invitation, and I love what you all are doing with Venus Edge. I think it's incredible. So please keep it up. We love it.
Great, great. And for the audience, stay tuned because we're going to have some other Venus Edge technology sessions on other thrombectomy devices very soon.
Okay.